Everybody, and welcome to Tuesday Training. I hope you're having a fantastic week. As always,
we are live from Austin, Texas, right here at Insurance Syndicate headquarters, and man, we have a great show for you.
Why am I looking like that? That's really bizarre. Well, hello there. There we go. I am not the master button masher, but I'm getting better. Hope you guys are doing well, man. It's Tuesday. And it's time for some Tuesday Training, the show brought to you by the DFY CRM. And thank you guys over at DFY for what you're doing. All the innovations that you create in that platform. It is definitely my CRM of choice. I got a lot of stuff to talk to you guys about today. Wow. I'm going to try to get through it as efficiently and simple as I can. But there are some more updates coming down the pike for the old Medicare world. We've already seen quite a bit. But we got more coming, and I want to talk to you guys about them a little bit. Nothing that I think is going to be so incredibly disruptive that our business is in jeopardy, as an example. None of that sky is falling garbage. If anything is true, the future is very bright in the Medicare space. It's just going to get a little more challenging in some areas. And we are going to talk about that. You may already know about the article that I'm referencing that I posted in the group yesterday that is coming down the pipe, but there is more than just that. So I've got basically, again, a lot of news to dive into, you guys. Some of it's good, some of it's a little crazy. The first thing that I want to point out is specific to the Medigap world. A few people have made comments in different Facebook posts or whatever about some of the changes that are happening in the Medicare supplement or Medigap policy world, where states are now, more states, I should say, are adopting the birthday rule. If you're not familiar with what the birthday rule is, that basically means that anybody that's enrolled in a Medicare supplement, once their birthday comes around again the next year, they get a guarantee issue right to change that Medicare supplement. Usually those rules require them to stay at the same or lower plan. They can't really go up, right? So they couldn't go from a plan G to an F or a plan N to a G. Some of that varies by state, but in most cases, it has to be like plan or lower, right? So if they were on an F and they wanted to use their birthday rule to move to an F, they can do that. If they want to move to a G, they can do it. They can downgrade, but they can't upgrade. But anyway, Virginia recently posted, and Indiana just came out and said they have now adopted the rule. Well, I found this little document here thanks to a buddy of mine, Sean Hendricks, over at Senior Security Benefits. He dropped this in one of the groups, and it shows a lot more states that are working on or have adopted the birthday rule for Medicare supplement plans. This is not an exhaustive list. These are all new states that are adding that rule. Some of them have already made it effective. Some of them have not yet made it effective. But it's important to know, because if you're working in these states, a couple of things. Number one, you're going to have an opportunity where if you find people that are unhealthy, but their Medicare supplement price has gotten way too unaffordable, that you're going to have a 30 or in some cases 60-day window where you can flip that plan for them and get them fixed up. So it's a useful tool to know about and have in your bag. Again, these are not all the states. Other states that are not listed on here, these are the new states. Other states not listed, we already know California has the birthday rule. They're pretty much the original state. Oregon adopted it a couple of years ago. Missouri has a similar one, but instead of it being on the birthday, it's on the policy anniversary date. Same exact concept, but in Missouri, they do it on the policy anniversary date, right? So if someone's Medicare supplement was effective June 1st, in the month of June, they'll be able to exercise their guarantee issue right to a same or similar plan. But this little chart here goes through the rules, right? You'll notice, like, for example, Iowa, their proposed effective date, and I'm not sure they've announced it unless I've overlooked it. Iowa's moving to the birthday rule. The original effective again was January 1st of 26, but I don't think they've adopted it quite yet. Indiana just announced that they're going effective on it. They're giving you a 60-day window. In Indiana, it has to be the same plan only, so you can't go up or down. So if they have a Plan F in Indiana and they want to flip it for another Plan F, they can do that, but they can't move to a lower plan. Some of the other states like Nebraska, you can see Nebraska's on this list now. They will be adopting the birthday rule. New Mexico, Ohio, Rhode Island, Utah, Virginia. These are a lot of the states that are doing it, right? Also on this, or like I said, not on this list are the states that already had it. These are all new states. So other than having it as a tool for you that you can use to help people that are in a tough spot, you have to also understand the implications of what this does to Medicare supplement rates. Any veteran in the space will tell you that anytime a state adopts the birthday rule, their rates go up because they have to in order to remain profitability, because now they can't underwrite and protect against those new claims that they're experiencing. Now, you can't make the assumption that everybody that exercises their birthday rule to get a lower rate on their Medigap policy is sick, but by and large, the majority of those folks probably have some claims that it's coming with them, and the carrier has no idea what the health situation of that person is when they're coming in guarantee issue. So they are using the amazing math skills that their actuaries have to try to calculate that, but it always, unequivocally, absolutely, always ends up in higher rates. So, for example, in Indiana, where Medicare supplement rates are pretty nominal right now, like in the $100, $80 to $100 range, $120 range, kind of like Central Texas here, you're going to see some higher rates, right? Like just look at Missouri as a great example. And I like to pick on Missouri because Missouri is a very rural state for the most part, overall, when you look at the whole scope of the state. Generally speaking, a state like Missouri, if it didn't have the birthday rule, would have much lower Medicare supplement rates, probably really similar to some of the rates you see in areas like Central Texas or Oklahoma, used to be Oklahoma, that were really low. Other than maybe in the St. Louis area where they would be high because of the urban density and stress levels that exist in an urban population. But because they have the birthday rule, those Medicare supplement rates are quite a bit higher. And I'm going off the top of my brain. It's been a bit since I've looked at Missouri rates, but I think the going rate for a Plan G in Missouri is about $150 now. Plan F even higher. I might be slightly off on that. You're welcome to correct me in the comments if you're like, hey, you're way off, but I don't think I am, right? Oklahoma, we've already seen some of their rates go up. This is going to be with all of these states that you see. So if you're in one of these states and the birthday rule is coming down the pike, just be prepared that you're going to see higher rates, period. But more importantly, also be prepared that, hey, now I've got a new tool in my belt, for better or worse. It is what it is, right? You got to take the good with the bad, that you now have another opportunity where you can help people who might be stuck in an overpriced Medicare supplement plan and they need to get to another plan. So if you're in one of these new states, maybe check it out with your state Department of Insurance. Check with one of the Medicare supplement carriers that you're working with. Verify, is this in effect now? Make sure I have the right rates that I'm looking at, etc. It might take a little bit for all of this stuff to kind of accumulate and come to full fruition. But definitely we are seeing a lot of new states adopt the birthday rule. I don't know if that will continue to be a trend. If now we're going to see like Arizona adopt it, Texas adopt it, Mississippi, Alabama, like some of these other states. I don't know. Maybe. It seems to be a pretty big trend going on right now. And it's been a push for a while to create a health. It's all, the way I understand it, it's all based around health equity, right? We want to make sure that everyone, regardless of their health conditions, have access to high quality care. And generally speaking, the only time that you can get that level of care within a Medicare supplement, if you have health problems, is if you can get in through open enrollment when you first turn 65 or you first enroll in Part B, and you don't have to deal with any health questions. No pre-existing conditions, no nothing. Everything's immediate. And a lot of us have always operated with that understanding that we tell people like, hey, this is your one chance to get your Medicare supplement with no underwriting. If you jump to a Medicare Advantage plan now, you may not be able to come back. They want to change that. I know at the federal level they want to change that, but it's interesting to see it filter down to these states, because one thing that is different about the Medicare supplement plans right? They are traditional supplemental health insurance. So they're actually managed at the state level, the state Department of Insurance. Medicare, right? The federal CMS department, they will come up with the rules of the game at the higher level. These are what the plans are. These are the benefits. These are how they're going to work. Like they come up with the rules that say, hey, people who opt into Medicare A and B post January 1st, 2020, for example, no longer have access to Plan F or Plan C. They'll come up with those rules. They structure the plans and then they hand them to the states to follow the state Department of Insurance regulations and how they kind of manage their insurance at that level. So these aren't federal rules that are getting pushed onto the states. These are states saying in their own Department of Insurance regulation that, hey, we want to adopt the birthday rule for our Medicare supplement carriers that are out here, right? In the name, and the only thing I can think of is they're doing it in the name of health equity. And that could certainly come with some pressure from the feds. I haven't seen any proof that the federal government is putting pressure on them to adopt these rules. Maybe they are behind the scenes. I haven't seen anything, and I look for this stuff all the time. So the way I'm seeing it right now is these states are coming up with this idea on their own. They're like, hey, in the name of health equity, we need to go ahead and institute the birthday rule so that everybody, regardless of their health conditions, gets access to Medicare supplement level care. At least they have an opportunity to get in once a year, right? There are other states like Connecticut, New York, Washington, where it's straight community rated, straight guarantees you all the time. You've probably seen some of those rates. Go try to buy a Plan F in Connecticut. You're looking at probably $250 or more, right? Same thing going in Washington, same thing in New York. And that's why, especially in New York and Connecticut, in a lot of cases, Medicare Advantage plans tend to thrive. So the implications of this further down the line are that, one, Medicare supplement rates are going up, right? Which could certainly drive more people to the Medicare Advantage world. Whether or not it's being done on purpose, I'm not sure. There could certainly be some things behind the scenes where these states understand that, hey, if we can make our Medicare, and I'm totally speculating here, if we can make our Medicare supplement less attractive by pushing the rates up, we can get better federal funding to grow our Medicare Advantage program here in the state. I don't know. Maybe. Could be some stuff like that going on. But ultimately, I'm going to say it's in the name of health equity that they want to make sure that high-level access of care is available, right? So we're seeing this come around. With that said, I got a whole bunch of other news to talk about, but that's the first little piece to kind of understand. If you listened to last week, I talked about the final rule, right? And I also talked about the payment increase to Medicare Advantage plans that's coming. The way they proposed I think it was a 5.1% increase to Medicare Advantage payment rates, which is increasing that. But the long-term trend, while it's been increasing Medicare Advantage payment rates, we've seen a downward trend on Medicare, original Medicare reimbursement rates to doctors, to hospitals, et cetera. Well, this just in. Where'd it go? There it is. This just in. I pulled this off of McKnight's long-term care news, but CMS is giving nursing homes a very positive surprise. And this is along with a 2.8% pay hike proposal. So that's some good news, right? Despite an underwhelming, as it says here in the text, despite an underwhelming 2.8% Medicare Part A proposed pay raise, nursing home advocates found reason to be encouraged on several other fronts after the fiscal 2026 SNF PPS rule. The increase proposed by CMS is significantly less than the 4.2% pay hike that occurred for this year and 4% the year before. But the proposal does not include eventual SNF value-based purchasing reductions that will affect some facilities. CMS estimated that those adjustments will be about $196.5 million during the current fiscal year. That is money basically back in the pocket of SNFs, right, by using value-based purchasing reductions. Going on, it says, hey, we applaud CMS for proposing a net Medicare increase of 2.8% for skilled nursing facilities this year. And while that proposed payment update focuses on Medicare fee-for-service, this has nothing to do with Medicare Advantage necessarily. This is Medicare, original old Medicare. So while the proposed payment update focuses on Medicare fee-for-service rates, let's remember that nearly 2/3 of nursing home residents rely on Medicaid. And an increasing percentage of short-term patients are now on a Medicare Advantage plan. He added, expressing a wish that the nation's leaders must ensure that our Medicare and Medicaid programs are strong, right? So we are going to see an increase from original Medicare to SNFs. It's not as high as they've gotten in the past, but it is some good stuff. It goes on. There's a few other things that they're talking about in that value-based care reduction. For example, here it says CMS withholds 2% of a provider's pay to fund the VBP program, the value-based purchase program, and nursing homes can earn back part of that through the incentive pay. Pardon me for that buzz you probably heard in the background there, right? They are also proposing to eliminate health equity adjustment that was to go into effect relative to SNF back in scoring. It was supposed to go in effective 2027. They're kitting that out. SNFs like that. So we are seeing some things where original Medicare is going to get a little stronger at the SNF side, which is probably going to prop up some of those SNF nurses and caretakers to badmouth Medicare Advantage like they tend to do. And I understand why they do. It is what it is. It's mainly because they hate prior authorization, right? And they feel like Medicare Advantage doesn't provide the same level of care in an SNF that, say, original Medicare does, but that's blatantly just not true. You know, the only problem with going into an SNF with Medicare Advantage is your PA problems. But once you get in there and approved, it's going to function basically just like original Medicare. We got another one here. Another pay hike. Medicare proposes a 2.4% pay hike for inpatient hospitals. It's also the lowest increase since 2019. So while it is an increase, it's not much. And the American Hospital Association slammed it as inadequate. Real quick in the brief here, it says that CMS is proposing to raise Medicare payment rates for inpatient hospital services by 2.4% next year, the lowest rate since 2019, and one that comes at a time of acute economic uncertainty. Hospital groups decried the proposed rate, which could cause their payments to increase by an estimated $4 billion in the 2026 fiscal year. So they're calling it inadequate. Still, CMS generally increases rates between proposed and final payment rules. Fairly simple there. I'm not going to dive super deep into this one. It's a basic thing. Look, hospitals are getting an increase like they always do, but it ain't as much as they want. Next up, and here comes the biggie, and we've got quite a bit to talk about in this one. So I posted this article in the group, right? This is from Fierce Healthcare, and it says, and this was several months ago, or weeks ago at least, I talked about this through a Kaiser Family Foundation analysis that they did, right? Where they said, hey, this Doge group is looking at slashing fraud, waste, and abuse spending, et cetera, et cetera. They definitely got their eyes on Medicaid. And it gave what they felt like was the most likely outcome, which is this one. And then they gave a whole bunch of other proposed items. You may remember that video if you saw it. There was about 150 ways, right? I posted it. It was the entire brainstorm from the House Ways and Means Committee that said, hey, these are all the different ways that we're going to investigate of how we could save money through Medicaid by trimming it down hopefully without affecting recipients. But they came out with the one that Kaiser thought they were probably going to do. And indeed, they will be ending the federal match for states' Medicare or Medicaid funding request. This basically means that Medicaid is going back to where it was in 2017 and before, that it will be fully funded by the state and the state only, right? Basically, and taxpayers within that state. That is it. So I'm going to read through some of this with you guys. The Center for Medicare and Medicaid Services will restrict federal funds for state-based programs that go towards certain priorities like rural, broadband, and student loan repayments. Interesting. The department is looking to return to the core mission of Medicaid by rejecting or not extending federal matching fund requests for designated state health programs and designated state investment programs under the old Section 115 or 1115 waiver authority. After reviewing these approvals, CMS has determined these programs were funded entirely without federal Medicaid funds prior to those approvals, and the addition of federal Medicaid funding does not render these programs as integral components of Section 1115 demonstration programs that the agency said in a letter. In a letter. I have that letter. Not that we're going to read the whole thing, but I want to pull it up for you. So here is the letter, 3-page letter that CMS sent to the states. And I'm just going to reiterate exactly what it said in there, right here. After reviewing these approvals, CMS has determined these programs were funded entirely without federal Medicaid funds prior, and the addition of federal Medicaid funding does not render these programs as integral components. As such, CMS has renewed concerns about the appropriateness of providing federal funding for these programs under Section 1115 Demonstration Authority and does not anticipate approving new state proposals of Section 1115 Demonstration Expenditure Authority, yada, yada, yada. In short, hey, you guys were paying for Medicaid on your own before. Why do you need us to pay for it now? So they're going back to pre-rules that said, hey, the feds are no longer matching the funds for Medicaid. The states are going to do it all on their own. Fairly simple, right? The government said it was worried that states use freed up state dollars as a way to reduce their overall obligation, and that these federal funds are either duplicative or do not always go to Medicaid members. So they have some issues on the funding, right? That federal funding isn't always making it to the Medicaid member, and that it's for programs like it lists at the top here, that some of these programs are being used for rural broadband internet and student loan repayments. And like that's, in their opinion, that's not what Medicaid was built for, right? So they are reducing that funding. What does that mean? Well, that means quite a bit of stuff. And before I jump into that, I'm going to give you a few other examples. CMS highlighted 5 examples of federal matches that will not be accepted going forward, including $241 million to in-home services like housekeeping in New York, $20 million in grants to rural high-speed internet in North Carolina, $17 million to a California student loan repayment program. Attorneys told Fierce Healthcare CMS is within its legal rights to shift the priority of Medicaid state waivers and reject certain requests based on the administration's objectives, and Congress does not need to impose itself. That said, it marks a meaningful policy shift, narrowing the scope of what counts as Medicaid reimbursable, especially for social and infrastructure-related investments like broadband. Furthermore, CMS said approval should not include expenditures associated with the provision of non-emergency care to individuals who do not meet citizenship or immigration status requirements to be eligible for Medicaid. I'll say that one more time. CMS said approval should not include expenditures associated with provision of non-emergency care to individuals who do not meet citizenship or immigration status requirements to be eligible for Medicaid. Pretty simple. Now, what does that really mean? What does that really mean? Well, it means quite a few things, and I'm going to go through. I have some notes here that I'm going to read. Bear with me on kind of some of the implications of that, right? So the key points are, number one, policy reversion. CMS is returning to a 2017 policy that discontinues federal matching for state programs outside Medicaid's traditional scope. And that's the real key there. Like, I know some people are going to say, hey, they're taking away our Medicaid. They're taking away a lot of the funding, but they're specifically taking away the funding for programs that they feel are outside Medicaid's traditional scope, like providing money for broadband internet, providing money for student loan repayments. housekeeping services, those types of things. Affected programs, initiatives like providing, and this is exactly what I just said, initiatives like providing broadband to rural health providers and other services addressing social determinants of health will no longer receive federal matching funds. I will say I'm a little concerned because this can be broad. Services addressing social determinants of health will no longer receive federal matching. Not sure I'm a fan of that one because we know that social determinants of health is in a lot of ways is very important, because one thing that we have found that is very true is that isolation and loneliness, as one example, which is a social determinant of health, furthers chronic illness, furthers depression and disease, right, and debilitation, right? So that could be an issue. State autonomy. States may continue these programs using their own money, but without federal support. So the states can continue providing those services in their Medicaid program, but not with the Fed money. They're only going to be able to use their own money. Oversight concerns. The policy change responds to previous concerns about the lack of guardrails. So that's, again, one of the big things that we've seen that is consistent, or seems to be consistent, with this Doge group and how they are trimming the fat, so to speak, right? Is that their concern is a lack of guardrails. Like, hey, if we're going to give you a bunch of federal money for your program, we want some guardrails up so we know how it's spent. I don't really see an issue with that. Personally, if I give someone money for a project, like, I want to know that they spend it the right way, right? I'm about to hire a dude to remodel my house. I'm going to give him probably $55,000, $60,000 to do some remodeling on my home. I want some guardrails set up on that money. I'm not just going to give it to him and go, here, go do some work. Do what you want. And then next thing you know, he's remodeling somebody else's house. So that's kind of the big concern there. So let's go through a few implications on this, and then I've got a few other articles on this topic that I want to share real quick. Number one, state budget adjustments. I think that one seems kind of obvious. The states will need to reassess their budgets to determine if they can sustain these programs without federal support. Program continuity. Some health equity initiatives may face reductions or discontinuation if alternative funding isn't secured. Policy debates. This move may spark discussions on the role of Medicaid in addressing broader social determinants of health and the balance between Fed and state responsibilities. Finally, monitoring outcomes. Stakeholders will have to monitor the impact of this policy change on healthcare access and equity, particularly in underserved communities. So we're going to go through a little bit more. I have another article I'm going to pop up on screen for you real quick. Present, share. So this is an article out of CAP. I'm not super familiar with this publication, but when I went through this, it seemed to be pretty on point. So number one, if Congress reduces federal matching rates, 12 specific states may reverse their Medicaid expansion, eliminating Medicaid coverage for more than 3.6 million people. So you may remember, right? Medicaid was expanded during the pandemic, right? During the coronavirus COVID-19 pandemic, federal emergency. But it's never really been pulled back. Some states adopted the expansion. Some states didn't. Some states have bigger budgets than others. Some states might be able to easily afford this, and some states not so much. So we're going to show 12 states that are likely going to be impacted the most if they do not eliminate, or if they do not reverse their adaptation or adoption, I should say, of their Medicaid expansion. Congressional Republicans, both chambers, have passed a budget resolution that directs the House Committee on Energy and Commerce to cut at least $880 billion in costs through 2020 or 2034. We've already heard about this. Since Medicaid accounts for 93% of the committee's spending jurisdiction, cuts are going to have to come from that program. So we talked about that a while back when they announced their budget, right, that they wanted to try to accomplish. The goal was to cut $88 billion in dollars, right, through federal programs. The largest part of that was definitely in the Medicaid space. Republican leaders on the committee have proposed lowering the federal medical assistance percentage For the Medicaid expansion population, adults with incomes of up to 138% of the federal poverty level who became eligible for Medicaid through the Affordable Care Act. More than 20 million Americans across 40 states and the District of Columbia have coverage as a result of the ACA's Medicaid expansion provision. So I want to be clear about that. That doesn't just mean people that are on Medicaid. Like Medicaid's expansion provision that they did in the ACA also increased the subsidies for ACA, right? So that other people or more people could afford ACA because now they can get it for free or $10 or whatever it might be, right? They can get a nice subsidy to reduce that. So some of this will certainly spill over in that space as well, and certainly could. It says if the federal Medicaid or medical assistance percentage is decreased, more than 3.6 million people across 12 states would lose that coverage. Let's jump into those states real quick. Pretty simple. They drop a graph down here for you. So again, this is based on if these states do not either decide to pick up the federal funding of the Medicaid expansion themselves, then these people are going to lose coverage through the ACA marketplace, right? This isn't people losing Medicaid so much as it is people that are most likely losing. No, yeah, this was lose Medicaid coverage. I thought this was specific to ACA, but they are still going at this from the Medicaid angle. So Arizona, about 124,000, not a big deal. Illinois, big one, 750,000. That's 250,000 people. So you might take a look at some of these states. And if you work in these states, and maybe let's say you work in the DSNP marketplace quite a bit, you're probably going to see some people lose Medicaid coverage unless the states pick up the slack on their own. If the states have the budget and they can pick up the slack on their own, then everything will move easy peasy for the most part. For states that collect the state income tax, you might see your taxes raised to help cover that cost. And again, I'm just speculating. It's one of the reasons I enjoy the great state of Texas. There is no state income tax. But right here, this chart tells you like these are some of the people that some of the numbers that they're projecting that are losing, right? But wait, there's more. But wait, there's more. Let me pull this out for you real quick, because not only are they looking to or not only will they be, I should say, not only will they be reducing the federal matching for Medicaid expansion and Medicaid programs, Medicaid work requirements are coming around again, right? And this actually, I overlooked this originally because this article, for example, was from February 18th, a couple of months ago. And it's 5 key facts about Medicaid work requirements, which is exactly what it sounds like. If you're on Medicaid, you better be working. If you're within certain parameters, not everybody, but if you're within certain parameters and you're on Medicaid, you better be working. That's kind of the juxt of it. But I'm going to get through this real quick. Work requirements in Medicaid have resurfaced as a part of a broader legislative package of potential changes to Medicaid designed to significantly reduce federal Medicaid spending. Reductions could help offset the cost of extending expiring tax cuts. I've talked about that before. We're trying, like, there's a big part of the reason why they're doing some of this is there's a whole host of tax cuts that were put in place, I believe in 2017, if I remember right, that they want to keep running. Those tax cuts are set to expire, and they don't want them to expire. So they're trying to save money on some of these other programs in areas that they call fraud, waste, and abuse so that they can re-sign those tax cuts for everybody. And I know that everybody likes to say that those tax cuts are just for the rich, but they're not. You are likely enjoying those tax cuts yourself today. So a draft bill introduced in the U.S. House of Representatives in February of 25 includes a minimum work requirement for certain adults enrolled in Medicaid as a condition of coverage. Pretty simple. If Congress does not include work requirements in federal legislation, some states will pursue Medicaid work requirements through Medicaid demonstration waivers. So if Congress doesn't do it themselves, some states are going to do it themselves, right? Why? Well, because they know that federal funding is leaving them. So they might be implementing some of their own work requirements. As an example, the first Trump administration encouraged and approved Section 1115 demonstration waivers that conditioned Medicaid coverage on meeting work and reporting requirements, approving 13 state work requirement waivers. Only Arkansas implemented such requirements with consequences for noncompliance, which resulted in 18,000 people losing their coverage. I'm going to move on that. Let's get to some of the 5 key points on this. Number 1, most Medicaid adults under age 65 are already working without a work requirement. Among adults under age 65 with Medicaid who do not receive Social Security disability benefits, supplemental Social Security income, or again, SSDI, and who are not covered by Medicare, right? So this is people under age 65 with Medicaid, not receiving any kind of supplemental Social Security income or disability income, and also not covered by Medicare. 92% of those people were working full or part-time. 60 or not working due to caregiving responsibilities. So they're either working, they're saying that 92% were either working full or part-time, or they were not working due to caregiver responsibilities. Some of them illness and disability. School attendance was a small fraction of about 7%. The remaining 8% of Medicaid adults reported that they are retired, unable to find work, or were not working for another reason. Those in better health with more education and without disabilities are more likely to be working. Pretty simple, right? So they're saying that, hey, this idea that Medicaid people need to be working, they're saying, man, 92% of them that are under age 65, right, not on Medicare and not receiving any type of supplemental income through Social Security or disability, they're already working. And the small percentage that's not is generally those that are not working because they are disabled, right, or ill, they're caregiving for someone else, or they're in school. That's according to Kaiser Family Foundation, which is probably spot on because Kaiser tends to keep their finger on the pulse of this stuff really, really well. Number 2, CBO estimates of national work requirements show lower federal spending and an increase in the number of uninsured, but no increase in employment. In April 23, U.S. House of Reps passed the debt ceiling bill, yada, yada. I don't want to go through all of that. That is the CBO report, right? So CBO, a 2022 CBO report notes high rates of employment among SNAP and Medicaid recipients that leaves little room to increase the employment rates further. Because again, most people that are under 65 and on Medicaid are already working in some capacity. A very small percentage aren't, it says. Number 3, in Arkansas, implementing Medicaid work requirements resulted in more than 18,000 people losing coverage. Arkansas implemented Medicaid work and reporting requirements with consequences for noncompliance before a federal court deemed the work requirement unlawful. The requirements were in effect from June 2018 through March 2019. More than 18,000 people lost coverage, or about 25% of the population subject to the requirement, primarily due to a failure to regularly report their work status or document eligibility for an exemption. So again, this is what they're saying. This has already been tested in Arkansas. 18,000 people lost Medicaid. Why? Because they didn't fit the requirements. They either weren't working or, like it says here, they weren't reporting their work requirements. Georgia has not expanded Medicaid under the ACA, but expanded eligibility under a pathways waiver to 100% of poverty level, not the full amount. The current waiver does not include any exemptions. The waiver was implemented in 23, and it goes. This one, in my opinion, really doesn't apply, but they're just talking about the number of adults that they ended up getting on Medicare or Medicaid, over a period of time, right? And that, again, most of them are working. They have a monthly work reporting. Number 4, evidence shows Medicaid work and reporting requirements are confusing to enrollees and complex and costly for states to implement. For example, in Arkansas, lack of awareness and confusion about the requirements were common because they have to report their work that they are still working, right? Despite robust outreach efforts, many enrollees were not successfully contacted. So that's going back up the number 2 up here, or I'm sorry, number 3, where it says this, right? It says more than 18,000 people lost coverage primarily due to a failure to regularly report their work status. So the process becomes problematic because it's confusing to those folks that are out there. And the states have apparently, at least in Arkansas, struggle to keep up with the outreach to get that done. It says for states implementing work requirements, it involves a complex systems change for enrollee outreach and education and staff training, and estimates the administrative cost to implement work requirements varies from anywhere from 10 million to over 270 million. Wow. And then finally, research shows access to affordable health insurance and care promotes individuals' ability to obtain and maintain employment. Research shows that being in poor health is associated with increased risk of job loss, while access to affordable health insurance has a positive effect on the ability to obtain and maintain employment. So they're right. They're kind of saying in an opposite environment. They're like, hey, man, we need to make sure these people still have Medicaid, because if we can get them good health insurance through Medicaid, we can probably get them healthy enough they can go back to work. Seems to be pretty reasonable. So I'll put this article up in the group for you guys to check out a little closer. But I got one more. Same topic. We're still looking at the work requirements. So this comes from Becker's. I just picked this one up this morning, and it shows all the different states that are ranked by potential coverage losses under Medicaid work requirements. And of course, California is right at the top. California is projected to experience the largest potential loss in Medicaid coverage if federal work requirements are enacted, according to an analysis by the Urban Institute. And I'm just going to scroll down here. These are the states that are ranked, right? So if Medicaid work requirements are instituted, and I'm of the opinion they probably will be, these are some of the predicted losses of people that will lose their Medicaid coverage. So in California, they're estimating somewhere around 1 million, maybe as much as 1.2 million people would lose access to Medicaid if work requirements are put into effect. New York, around 250,000, maybe a little more. Illinois, 200,000-ish, right? And it scrolls on down to the bottom. North Dakota, maybe only 5,000. Well, shit, there's only 5,000 people that live in North Dakota, isn't there? So this could be interesting to you if you're in one of these states. And this is what I'm trying to get across to you guys. Like, I know I'm going through a lot of legal stuff and laws and rules and legislation and so forth, but what I'm trying to get you to understand is that if you're in a state, or I should say, if you are focused in the Medicare space, and more importantly, if you do a lot of work in the Medicaid space with dual eligibles, you're going to see some disruption, especially if you're in some of these top states up here, because you are likely going to see a lot of people lose their Medicaid status in different ways. Not so much for us that are working with people over 65, because the Medicaid work requirements don't apply to them. So I'll have to backtrack a little bit of that. But I have people in my own book of business that are 45 years old, and they're on Medicare and Medicaid, and they're on a DSNP. I've got a handful of those people in my own personal book, right? And I know we have quite a few with some of the agents that I work with. So some of those people, if they don't get a job, I guess, they're probably going to lose Medicaid coverage, right? And more importantly, a lot of these people are going to lose access to ACA because they're going to end up losing subsidy monies as well, most likely, if these expansions are all pulled back. So I think I got a couple more. Let me double check something. Yeah, I'm going to put this one up here. It's specific to Arizona, but it's a little bit more on the work requirement stuff that I want to go over, so you kind of get a better idea of what they're talking about there. Is that it? Yeah, that's it right there. So this is Arizona's plan, right? Arizona's proposal to add work requirements and lifetime limits to Medicaid is under federal review with public comment until May 9th. Whoa. Bounce. Oh, come on now. Well, now it's putting me through a paywall. Sorry. I'll have to get that one reloaded. My apologies. That one got messed up for me. I'll get back to that one at some point. Let's see. Yeah, I don't have it here in front of me. I'll get to that article and I'll get in the group, but it goes through a little more detail on like how it's working in Arizona, what they're doing, goes through a little bit of positive, a little bit of negative on how that whole process is working. And Finally, I don't have time to go through this, but I will get this in the group. And this might be something that I talk about next week. But this excellent, and I'll just show it to you real fast. This was a giant study that was done through Inovalon that goes through Medicare Advantage versus traditional fee-for-service Medicare based on different populations, different outcomes, whole thing. We're talking coverage levels, health outcomes, etc. I haven't had enough time really to dive into this yet to where I feel like I can speak like super deep on it. So I'm going to study that one a little bit and I will jump to that one next week. But other than that, I believe, let me make sure, I don't want to leave y'all with something. Let's. Yeah, no, that's going to be it. This is just a chart. I'll put this another Kaiser Family Foundation chart that goes over some of the Medicaid stuff. I will get that in the group for you guys. But again, ultimately, not the whole crux of the show is like, look, a lot of the trends are continuing, right? The hospital reimbursement rates, while they are getting increases, those increases are lower. So again, it goes back to something I've been saying for a long time. Reimbursement rates under original Medicare continue to go on a downward trend. Payment rates and reimbursement rates to doctors and hospitals, et cetera, on Medicare Advantage continue on an upward trend. And Medicaid is about to get tight for a lot of people, right? So that's kind of the crux of the show, man. I hope you guys got some value in that. I will take some time and get some of these articles in the group so you can examine them a little further. But otherwise, buckle up for a wonderful year. It's going to get disruptive. It is going to get somewhat challenging in some areas, but ultimately, the future is definitely still very, very bright in the Medicare space and in the Medicare Medicaid space. You're just going to have some new challenges that you're going to have to work through and make sure that you got these people covered the right way. Thanks again for tuning in, man. I'll see you guys next time, next week, Tuesday training. Peace.